Hi friends, let's discuss a very important topic and a very common topic, acute appendicitis. So the keywords used in this discussion are the following: Alvarado score, Blumberg sign, Row 6 sign, Dunphy's sign, Cope-Soas test, Cope's operator's test and Baldwin's test. So let's discuss acute appendicitis under the following headings: an introduction, etiopathogenesis, clinical features, differential diagnosis, investigations, treatment, complications of appendectomy, and a few words about laparoscopic appendectomy. Now, what is the meaning of acute appendicitis? What is appendicitis? Of course, anything which has itis at the end is supposed to be inflammation. So, appendicitis is supposed to be inflammation of the appendix. Simple. It is called the great mimicker of the abdomen. Why? Because sometimes a patient with appendicitis may present to you with say fever, sometimes with loose stools, sometimes with a typical abdominal pain, sometimes with a swelling in the abdomen. Sometimes a patient may just say that he or she has nausea or vomiting. Sometimes a patient won't have any complaints, but still you will be able to pick up clinically or radiologically some features of appendicitis. So this is a great mimicker. It can mimic any other condition, or sometimes appendicitis could be asymptomatic, and so it is called the great mimicker of the abdomen. So neurologically, nobody can say for sure that the patient is having appendicitis or not. Clinically also, sometimes you may not be able to say that patient is having appendicitis or not. Even intraoperatively, you may not be able to say that patient is having appendicitis or not. Sometimes histologically also, they might say that yeah, features are suggestive of some inflammation, but like that. So it is definitely called the great mimicker of the abdomen. Now let's have a look at the etiopathogenesis of acute appendicitis. Why does a person develop acute appendicitis? Now this is a big of a confusing thing. That is, mostly the reason is unknown, but if you really want to point out certain things which probably predispose for developing acute appendicitis, you have the 6 F's. The first F is fecalith. Lith means what? Stone. Okay, feco, feces. So a stone, a feces or fecal matter forming a stone which is blocking the appendix can lead to pooling up of secretions distal to it, and that can lead to inflammation, right? So that is fecalith. Fecalith is considered to be a common predisposing factor for developing appendicitis. Second is fiber deficiency in the diet. Now what does a fiber do? When you have the colon here, you have the appendix here, you have the ileum here. Fiber helps in the smooth transition of fecal matter. Okay, it prevents constipation. Suppose there is lack of fiber, what will happen? If there is lack of fiber, fecal matter will be struggling for peristalsis. It will go very slowly, and when it goes very slowly, there is high chance that it will get accumulated in the appendix where it is not supposed to get accumulated. So lack of fiber in the diet will predispose for appendicitis. Next is a false use of purgatives or abuse of purgatives. Next is family history. To a certain extent, you may note that appendicitis, certain families are prone to develop appendicitis, probably because of their similar diet or maybe because of their similar genetics, but nothing is sure. Okay, next is foreign bodies, worms, strictures, adhesions, bands, Crohn's disease, or that's an inflammatory bowel disease, or carcinoma. Now what all does these do? They just cause an obstruction, whether it is a foreign body or a stricture or a carcinoma. All these things are actually causing obstruction at the base of the appendix, which lead to accumulation of fluid and collection inside the appendix, which finally develops into an inflammation, right? And further down obstruction. What do you mean by further down obstruction? Further down obstruction means, if this is the appendix, this is the ileum, if there is an obstruction at the level of the further down, that is further from the appendix, at the level of the colon, what will happen? Fecal matter will get accumulated. When it doesn't have space to get accumulated properly, it will use up the space provided by the appendix also. Again, when fecal matter gets inside the appendix, gets accumulated, it will get inflamed. And form appendicitis. What are the common organisms that cause appendicitis? They are the usual normal flora of the gut, like E. coli and Escherichia coli, enterococci, sometimes streptococci, anaerobes, bacteroids, Clostridium welchi. All these can cause appendicitis. Now, what is the pathogenesis? Once more, see, there is an obstruction at the level of the base of the appendix, and there is accumulation of substances inside this, or collection. Finally, what happened? When there is lot of collection over here, what will happen is that the appendix will be overfilled with these collection, and that can lead to inability of proper venous and lymphatic drainage. That will block the lymphatics and venous drainage. As a result, that appendix will undergo ischemic changes, right? Blood supply is compromised, venous drainage is compromised, it will undergo ischemic changes, and finally what happens when it becomes dead, friable, it will perforate. See, it has perforated. So in non-obstructive cases, there are certain non-obstructive appendicitis also. It is not always due to fecolith. So in non-obstructive appendicitis, there is an inflammation and it can resolve because there is no obstruction. But the problem is that once there is an inflammation, when it resolves, it becomes fibrous. The appendix becomes fibrous. It is no more the normal appendix. So there is high chance that the next time it can recur, because the normal defensive mechanisms of appendicitis are altered once there is fibrosis, and so there is high chance of recurrence. Obstructive appendicitis is what, like I earlier said, that is lymphoid hyperplasia. See, when there is appendix over here, there are certain lymph nodes called the payers, patches, etc. in the mesentery. Now suppose this appendix gets inflamed, what happens? These lymph nodes will also get inflamed due to the infective and inflammatory conditions, and they cause some level of obstruction such that the venous drainage is blocked, the lymphatic drainage is blocked, and finally it undergoes ischemic changes. When it undergoes ischemic changes, what will happen? Finally, it is going to break down and perforate. Once it perforates, what will happen? It will lead on to peritonitis. Or once it perforates, what will happen? There is a policeman inside the peritoneal cavity called the omentum. The greater omentum will come and try to seal off this perforation. Okay. As a result, what will happen? The appendix which has perforated along with the greater omentum will form a mass, which is called the appendicular mass. Okay. Now, when there is a mass formed but the infection is progressing, what will happen? It becomes an appendicular abscess. So first it was a mass, but due to continuing infection and inflammation, it becomes an appendicular abscess. Appendicular abscess can later on break and form peritonitis. Sometimes mass formation won't be there. The appendicitis is so severe that there is no mass formation. Simply it breaks down and the patient will be presenting straight away with peritonitis. So there is lymphoid hyperplasia, which lead on to accumulation of fluid and mucus inside the lumen of the appendix, increased intraluminal pressure due to the collection, and that blocks the lymphatic and venous drainage, ischemia, ulceration, necrosis, gangrene, and finally perforation and peritonitis occur, which may be prevented by the greater omentum, and it will form a mass and then finally an abscess. So that is the etiopathogenesis of appendicitis. Now coming to the clinical features. Typical clinical features, as I told earlier, it can be just fever or abdominal pain. Actually, any person who comes with right lower abdominal pain, the first thing that should come to your mind, the first thing that you should rule out is appendicitis. Why? Because it is dangerous. It can break and lead on to peritonitis, right? So any patient with lower abdominal pain should be suspected of appendicitis. Now there is a score called Alvarado score. Alvarado score is a score which was developed to assess the severity of appendicitis, also for diagnosis of appendicitis. Now the first thing is migratory pain. Remember, Alvarado score has a mnemonic called mantras. Out of this, the first one is migratory pain, which means there is pain around the umbilicus due to distension of appendix, which later on localizes to the right iliac fossa and finally becomes diffuse. It means that, see, this is the ileum, this is the appendix, you have the colon. Now around each intraperitoneal organ there is a visceral peritoneum, okay, which cannot be divided or separated from the organ. Other than that, around the peritoneal cavity you have the parietal peritoneum. Now first what happens, first there is inflammation at the appendix. Now what happens, this violet color, that is the visceral peritoneum, is affected, and the visceral peritoneum is continuous with all the other organs inside the peritoneal cavity. So what happens, there is a pain, patient will complain of pain around the umbilicus because visceral peritoneum is irritated somewhere. Wherever the visceral peritoneum is irritated inside the peritoneal cavity, the pain is referred to the umbilicus. Now what happens, the inflammation progresses beyond the visceral peritoneum and reaches the parietal peritoneum. Once the parietal peritoneum is affected, the pain will be localized only to that area where it is irritated, which in case of appendix is at the right iliac fossa. So that is called migratory pain. First the pain was around the umbilicus and now the pain is in the right iliac fossa. And finally what happens, once it disrupts, once there is perforation of the appendix, what will happen, all the fluid and fecal and matter, everything which was accumulating inside the appendix will be spread on throughout the peritoneal cavity. The entire parietal peritoneum will be irritated and so the pain will be diffuse. So if there is migratory pain, you give 0.1, 1 point is given. Anorexia if present, 1 point is given. Nausea or vomiting if present, again 1 point is given. Tenderness at the right iliac fossa is more specific towards appendicitis, so 2 points are given. Okay. Rebound tenderness at McBurney's point. What is rebound tenderness? Rebound tenderness means, see, this is the appendix, appendicitis, and you have the parietal peritoneum here. Suppose you are applying pressure over here. What will happen? The parietal peritoneum will be pushed towards the appendix, and you are applying that pressure so gently that the patient may not feel an extra pain. An extra pain won't be there. But suppose you release this pressure, what will happen? This parietal peritoneum will rebound back. Now when the parietal peritoneum sticks onto the appendix, okay, the pain won't be there. But when it is getting released from that sticky area of the inflamed infective appendix, it will cause severe irritation to the parietal peritoneum, so much so that when you apply pressure in the right iliac fossa and then release it suddenly, patient winces with pain. Till that time, you would be, trying to distract the patient, trying to slowly palpate in and around the appendix, but at the moment you take the hand, patient will wince with pain, patient may even swear at you. So that is rebound tenderness at McBurney's point. Which is McBurney's point? McBurney's point is this point. It is on the line which is joining the umbilicus to the ASIS, anterior superior iliac spine, at the junction of the lateral 1/3 and medial 2/3. This is the point of McBurney. Okay, this is the point where usually appendix is found in most of the patients. So tenderness, rebound tenderness at McBurney's point is another clue towards appendicitis. Elevated temperature, that is fever, because it's an infective and inflammatory cause, it is expected. So another 1 point. Okay, 1, 1, 1, 2, 1, 1. Leukocytosis, that is WBC count is elevated, should be given 2 points. And shift of WBC count to left, which is more of neutrophils, more than 75% of neutrophils, is again a favorable point towards the diagnosis of appendicitis. Other than that, patient may have urinary symptoms, bowel symptoms, etc. So how do you remember which is given 2 points and which is not given, which is given 1 point? I remember it like this: man Mantrels, mantrels or mantrels. Okay, there are two syllables for this word, mant and trels. So at the end of each syllable, you have to give 2 points. Mant, which is T, and rels. S of course is shift to left. Shift to left, you can't diagnose it clinically, right? So it is not given much importance. But rel is definitely something which you can check otherwise also. I mean, shift to left, you have to do DC, the differential count is needed. But TC or total count is enough to diagnose leukocytosis. So leukocytosis is an easier thing to get, and so L should be given 2 points. So total you have 10 points. 5 to 6 out of 10, it means there is a probability of appendicitis. I mean, there is a suspiciousness for appendicitis. 6 to 9 means it is probable. Above 9 means it is definitely confirmed to be appendicitis. Okay, so that is the Mantrel's score or the Alvarado score. Now coming to certain clinical features. Of course, like any other case, you have to do a general examination, inspection, palpation, auscultation, and percussion and auscultation. Now for appendix, there are certain named signs. The first one is the Blumberg sign. Blumberg sign is already something which we have discussed. That is when you apply pressure to the McBurney's point, which is at the lateral 1/3, junction of the lateral 1/3 and medial 2/3 of the line joining umbilicus and ASIS. Once you apply pressure and release it, patient will wince with pain at McBurney's point. So that is called Blumberg sign. Second one is Rosick sign. Rosick sign means you are applying pressure at the left iliac fossa. Patient will complain of pain in the right iliac fossa. Why? Why? Because there is a lot of bowel inside over here. So when you are applying pressure over here, these bowel will be pushed towards the right iliac fossa and will be applying an indirect pressure to the inflamed appendix, so the patient will develop pain. Next is Dunphy's sign. Dunphy's sign is very easy. You just ask the patient to cough and patient will say that patient has a localized pain in the right iliac fossa. Sometimes you can even apply pressure at this point and ask the patient to cough. Patient will be saying, oh, I can't cough because it is paining so much at the point where you are touching. So that is Dunphy's sign. Next is Cope's-Soaz test. Cope-Soaz test and Cope-Obturator test are the two other tests for acute appendicitis. Now, Cope-Soaz test means what? The psoas muscle is being tested or put under stress. Okay, this is how you do Cope-Soaz test. Which means you have to ask the patient to be in the left lateral position. Ask the patient to hyperextend his knee as well as his hip. So what happens? If the appendix, which is over here, is retrocecal in position, what happens? It will be pushed more towards the posterior peritoneal wall. The appendix, which was lying over here, when you hyperextend the hip, it will impinge on the posterior abdominal wall and cause pain. So this is a test for retrocecal appendix, retrocecal appendicitis. That is Cope-Soaz test. You are stretching the psoas muscle and that's why it's called Cope-Soaz. Next is Cope's obturator test. In Cope's obturator test, what you are doing is you ask the patient to flex the knee and you are going to pull the leg towards one side, whereas hip towards the opposite side. Hip medially and the leg outward, that is laterally. Here you are stretching the obturator muscle. Okay, again, if there is an appendix which is inflamed, it will impinge on the especially retrocecal appendix will impinge on the stretched obturator muscle and cause pain. So that is the Cope's obturator test. Next is the Baldwin's test. Baldwin's test is very simple. You just ask the patient to raise both his lower limbs, okay, without flexing the knee. Ask him to raise both the lower limbs upwards and patient will wince with pain when it reaches a particular angle. Why? Because while flexing the hip, you are actually putting pressure over the inflamed appendix. So that is Baldwin's test. Okay. Now coming to the differential diagnosis. Like I said, appendicitis is a great mimicker. Any pain in the abdomen could be appendicitis. Sometimes no pain can also be appendicitis. Any acute conditions of the abdomen can be appendicitis, can mimic appendicitis. Like for example, a perforated peptic ulcer or Crohn's disease, which is inflammation, acute pancreatitis, acute cholecystitis, acute perforation, acute Meckel's diverticulitis, acute ureteric colic or acute enterocolitis, acute pyelonephritis, mesenteric lymphadenitis, typhlitis. All these are all inflammatory and infective conditions which can happen to anybody, and it might be mimicking acute appendicitis. Now, there are certain differential diagnoses which are commonly seen in a pediatric age group, like Meckel's diverticulitis, intussusception, acute colitis, roundworm colic, acute iliac lymphadenitis, because in pediatric population, mesenteric lymph node enlargement, lymphadenitis is very common. Lobar pneumonia, even lobar pneumonia can mimic acute appendicitis, especially in pediatric population. Okay, now there is a gynec population or female population who have other differential diagnoses like a ruptured ectopic, anything coming from the ovary and the tube like ovarian distortion or a Mittel's pain or even salpingo-oophorytis. All these can mimic acute appendicitis. Other than that, in elderly population, you have to be vigilant. It could even be diverticulitis, intestinal obstruction, carcinoma cecum, aortic aneurysm, leak, that is ruptured aortic aneurysm, mesenteric ischemia, Crohn's disease. All these may look like acute appendicitis but may be something more severe. Now coming to the investigations. Of course, to check for leukocytosis and shift to left, you have to do a total WBC count. USG abdomen may give a clue that this is appendicitis. Okay, it shows a non-compressible bowel of size more than 6 millimeter in anteroposterior diameter, hyperechoic thickened appendix wall is also a feature of inflammation, more than 2 mm. Target sign. What is target sign? See, this is target sign. You are targeting at a single point. It is because there is a wide base and a blind ending. So from a particular angle, it will look like a target. See here also target sign. Thickened appendicular wall. Usually appendix is hardly seen in an ultrasound. Appendicolith means inside the appendix there is a stone, probably the fecolith. Periappendicular fluid, maybe because of the inflammation or maybe because of the formation of a mass or evolving abscess or etc. Laparoscopy can be done to check if the appendix is normal or not. If USG abdomen, you can't completely depend on the radiological diagnosis in case of acute appendicitis. So in case of doubt, you can do a laparoscopy or imaging, better imaging like CT, MRI or X-ray. In X-ray, there might be a lumbar scoliosis to the right. See, this is the spine, this is the appendix. There is a natural or a tendency of the spine to bend towards the inflamed appendix, that is lumbar scoliosis. CRP may be elevated in case of sepsis and inflammation. Now coming to the treatment of appendicitis. Of course, you can try a conservative treatment by keeping the patient NPO, that is non-peroral, give antibiotics, give fluids, and check if the pain is coming down, if the patient is not willing for surgery. But always there is a chance for recurrence, there is a chance for abscess formation, mass formation, peritonitis, sepsis, everything. So the definite treatment is definitely a surgery. Okay, so now let's discuss the open appendicitis. First of all, incision. The commonly used incision is the Lance incision. Okay, so this is the Lance incision, this is the Lance incision, which is done at the McBurney's point, oblique incision. You also have a modified Lance incision, which is more slanting. Then you have Rocky Davis incision, which is the horizontal incision. If you are extending it laterally, it is called the Rutherford Morrison incision. If you are extending it medially, it is called the Fowler wire incision. So all these incisions can be used for open appendicectomy. What is done finally? The skin, the submucosa, the subcutaneous tissue, the two fascia, Camper's and Scarpa's fascia and all is incised by deepening the incision. Finally, you find the external oblique aponeurosis like this. Okay, that is like inserting your hands inside the pocket. Inside the pocket, you just split it open along the direction of the fibers, and you will find internal oblique muscle and the transversus abdominis, that you're supposed to open up by retracting. Just open up these fibers on either side. Just split it open and then you will find the peritoneum underneath. Once you find the peritoneum, what do? You put a hole inside the peritoneum, put your finger inside that hole, okay, or just retract it very well so that you can finally see the peritoneal cavity. Inside that, the cecum is identified first. Identify the cecum first. How will you identify? This is the ascending colon, this is the cecum, and this is the appendix. It is continuous with the ileocecal valve here, right? Now, the good part about cecum and ascending colon, large intestine, is that it has tinea. Tinea coli are strands of longitudinal muscle concentrated at 3 levels around the colon, and they converge to form the appendix. So if you find a tinea coli, just trace it on either sides until you find that all the tinea are converging to a particular point, which is supposed to be the appendix. So by checking the tinea as well as by identifying the ileocecal junction, you can find what is the cecum, and if there is an omentum surrounding the appendix, it is separated. Mesoappendix and appendicular artery is divided. These are the positions of the appendix. It could be retrocecal, like this, or pelvic, or pre-ileal, etc. Right? Now, what is done is that this is the mesoappendix, right? Mesoappendix is there, and inside the mesoappendix you have the appendicular artery. Now, what you have to do is that you have to ligate it. You have to clamp it on either sides. Okay, you are supposed to clamp it here, and then divide it in between, and you can ligate it on either sides so that it won't bleed anymore. Okay, here it is cut, and you have tied it on either side so that it won't bleed anymore. And once the mesoappendix and the appendicular artery is dealt with, you have separated the mesoappendix from the appendix. Then what you do? Using a thread, you have to apply purse string suture. Purse string suture means what? You have to put a continuous suture around it. Suppose this is the appendix, you will have to take sutures like this. See? Like this, like this, like this, like this, like this, like this, like this. So that if you approximate it and pull these two ends, finally they will occlude the lumen of the appendix. So purse string sutures are applied at the base of the appendix, and you have to crush the base. How will you crush the base? This is how you crush the base. Okay, that is by applying a clamp, and you just put a lock it once, and you'll find that the base is crushed. And then what you do? You have to transfix the base. So by the time you'll have put a purse string suture at the base, you might have tightened it, crushed the base, and then you're dividing it. See, this is another loop. Loop knot can also be done before dividing the appendix. So you have divided the appendix here. So appendix is crushed with the artery forceps, and the base is transfixed. Not only by using a purse string suture, underneath the purse string, you can apply one more stitch, okay, such that there is a stump for the appendix which is less than 3 to 6 mm. So it is transfixed, the base is transfixed, and then the appendix is divided distal to the crushing point, and the stump is cleaned with antiseptics. Post-operatively, give the patient some IV fluids, antibiotics, etc. until the patient recovers completely. Now this is the picture of an acute appendicitis. See, the gangrenous changes, ischemic changes, etc. have settled in. Now, what are the complications for appendicitis, surgery of appendicitis? One is paralytic ileus. The moment you open peritoneum, there is always chance of paralytic ileus. Second is reactionary hemorrhage. Reactionary hemorrhage is when the suture which you applied at the mesoappendix to occlude the appendicular artery, that may get loose or something. Residual abscess. Sometimes there could be a pelvic or paracolic or local or subdiaphragmatic abscess which went unnoticed during surgery because you are opening up only a small portion of the peritoneum. Your incision is small, you are delivering the appendix through that incision, you are not able to check the rest of the peritoneal cavity. Adhesions can develop. So if this is the cecum and you have done an appendicectomy, you have the parietal peritoneum here. While the stump is healing, it can get adhered to the peritoneum. That can cause obstruction, intestinal obstruction, in future, and so kinking can also occur, so adhesions can develop, right inguinal hernia can develop because this incision which you are using for appendicectomy can injure the ilioinguinal nerve, which can cause a localized muscle weakness, and that can cause inguinal hernia. Wound sepsis can occur, fecal fistula can occur, that is if the stump gives way and it opens to the peritoneal cavity and through the skin, there could be fecal fistula. So that is also a possibility. Respiratory problems can occur, deep vein thrombosis can occur. These are the complications of appendectomy. Now coming to laparoscopic appendectomy. Now there are certain advantages of laparoscopic appendectomy. For example, the whole of the abdomen is visualized. You won't miss any pelvic abscess, subdiaphragmatic abscess, etc. In females, pelvic structures can be assessed properly, which cannot be assessed when you are doing a small incision appendectomy, open appendectomy. Trauma of the axis is less, yes, the wound infection of the scar, etc. is minimized, and faster recovery. Disadvantages of lap is that technical difficulties are definitely there, especially in burst appendix. Suppose the appendix has burst, you put a scope, you will find only this pus, right? And plus the appendix is too huge that you may not be able to remove it through the pot. Okay, cost factor and availability are all other factors. For lap appendicectomy anyway, the incision which we put is one is the periumbilical incision, could be supraumbilical or infraumbilical, one towards the left iliac fossa and one in the suprapubic area. In case you are not able to access the appendix through this properly, you can always put an extra incision near the right iliac fossa so that you can easily access the appendix. So the questions which can come from this session are about acute appendicitis, causes of RIF pain, the differential diagnosis, laparoscopic appendicectomy, steps of open appendicectomy can even be asked during your practicals for viva sessions like operative surgery. MCQ number 1, all are typical signs related to acute appendicitis except Blumberg sign, yes, Rossig's, yes, Dunphy's sign, yes. Gray Turner is typically seen in cases of acute pancreatitis and necrotizing pancreatitis, not in acute appendicitis. Next, all are complications of acute appendicitis except mass is definitely there, rupture, abscess is definitely there, but malignancy, no, it isn't a typical complication. MCQ number 3, all are components of Alvarado score except mandrels. So just check for all these alphabets. R is there, A is there, E is there, S is there. So that is not enough. So shift of WBC count to right, that is wrong. It is towards the left. So this is the answer. With that, we have come to the end of this session. Until we meet next time with another session. Bye-bye.
Docemy.